Welcome, welcome, everyone. Welcome to evidence-based treatments in couple and family therapy. I'm so excited that you are here. And as you are joining, go ahead and put your name and where you're joining us from in the chat. It's always fun for me to know kind of where folks are coming from and joining from. So go ahead and put your name and where you're joining from in the chat. And we will get started as people are logging in. We got Katrina from Phoenix. Great to have you here. Who else? Go ahead and put your name in the chat. Sandy from Israel. Oh, great to have you here. I can't imagine what time it is there. Jasmine from New York. We got Sasha from Michigan. Marsha from Seattle. Austin, Texas. Michelle. Uh, Testney from Minnesota. Hope I got that right. Maribel from Dallas. Awesome. We got Doc. Oh, wait. Someone from Orange County. Awesome. uh, Rajvid from Orange County, close to me. Great to have you all here. Dallas, Cheryl from Chicago, Michelle from Colorado, Tanya from LA. That's where I'm at right now. Libby in Nebraska. Uh, we got someone else from Dallas, Carissa. Got Ellen from Nevada, Evelyn from LA. Hi, Evelyn. Novia from Alaska. Wow, I don't have a lot of folks joining from Alaska. I love it. Tammy from Ventura. That's my county. We have Senna from West Africa, from Ghana. Very exciting. I'm off to Kenya this summer, my first visit to Africa. So I'm just learning a lot and planning. Andre from Vancouver. Awesome. Great to have you here. And we have Jerry from Fort Worth and David from Maui. Aloha, David. Aloha, that is where where I wish I were at the moment. And Ari from San Diego. Love it, love it. Great to have you all here. I apologize if I missed anyone's name as this chat was scrolling up, but it's great to have you here. So, okay, so let's get started here with evidence-based treatments in couple and family therapy. And we're going to be going over the group treatments specifically today. And if you have um, my textbooks, it is chapter 10, I think, in the latest one. And you'll notice that I do move my chapters around. And it's the professors who really, I think, I know annoy the most because they have to redo their syllabi every time. And it is surprisingly hard to do that. So my apologies to any professors listening. Um, but this is some good information because some of the best approaches, the best evidence-based treatments, surprisingly, in couple and family therapy are these group treatments. And we're going to talk about them today. So it's really an exciting topic. And this is an area where these approaches, that many of these approaches we're talking about today, are underutilized. They have some of the best evidence base in the entire field of psychotherapy. And there's some of the more underutilized ones. And I think getting, couples and families in a group is sometimes, challenging. Um, but today you're going to learn about them. And if any of these really pique your interest, what we're talking about today are really great ways to expand, your practice, whether you're in a private practice or in an agency or hospital setting. These are really important treatments that there are not enough people who are trained and skilled in these using them. So let's go ahead and get started. See? Oh, sorry, there we go. And for those of you who are students someplace where a letter of attendance actually can be used in some university settings as evidence of professional training, you have to stay for the live workshop to get that. I will drop a URL in the chat. I made sure that we have the correct letter going out today. Isn't that impressive? We'll get it right today, I promise you. Um, so so that will go out, but don't count as CE certificates as far as I know for any other state organization or licensing board, but you have to check with your licensing board to find out. But for most students, these do count, but you have to attend live because otherwise it just becomes very expensive for me to issue these after the fact. And if you're watching this on YouTube after the live session, you can register at therapythatworksinstitute.com/YouTube live. And You can see the upcoming ones. We have another one next month will be the Gottman couples therapy approach. I take the month of July off, but starting in August, we'll be coming back and I will be doing a totally new series to do all the traditional counseling and psychotherapy theories that go in my counseling textbooks. So we will be doing one a month, and that will take me a good 2 years. So stay tuned for that. So let's go ahead and jump in here. So, lay of the land. Multi-couple, multi-family groups. The first one we're going to talk about is designed for severe mental illness. And this group has some of the best research in the field, and it is one of the most underutilized. And it's kind of a fascinating situation because there's over 50 years of research these are really powerful. And hope if you find it interesting, I encourage you to work on that and develop that skill set. We're going to talk about some fascinating research on multi-couple groups for partner abuse and domestic violence, intimate partner violence. This is also just really fascinating research. I know it kind of upsets some people, but we're going to go through what the research actually shows, which is different than what most of us, including me, were taught in grad school. We'll talk about marital enrichment, which, boy, I'm telling you, we need more of these groups right now in society. And then finally, parent training. So these are for the types of multi-couple, multi-family groups that have the most robust research behind them. And so it's, I think, really important that anyone in the field of mental health is aware of what these groups are and how they work and their outcomes, because these are really critical. And for the most part, they are not done frequently enough for people who would really benefit. Okay, so let's just start with some myths about evidence-based treatments. The first is that we don't need theory if you've got an evidence-based approach, and that is certainly not the case. All of these evidence-based treatments are actually built upon multiple theories. And so in some ways, most of these evidence-based treatments are integrative approaches where they've cut and pasted together several different concepts and interventions from various theories to create a very specific manualized treatment that has been, through research, identified to work better, usually better than average. At the minimum, hopefully work better than average. Many of these work better than average than standard treatment. Another concept is that theory and research are totally separable, and all of these evidence-based treatments are based on theory, and the two kind of usually evolve back and forth. The theory kind of refines the research, and the research refines the theory. Another, I think, common misconception around evidence-based treatments is that they are rigid and robotic. And there are very few approaches that where if you actually get formal training in it, you have to deliver it in this very kind of rigid manualized treatment. So the manual's a guide, but you still need a human and you need that relationship to deliver these methods. And think of these evidence-based treatments as kind of combining certain ingredients in a certain way to have optimal results. You, one thought is, so some people feel like they have to give up their personal theory of choice to use an evidence-based treatment. And, you know, the one thing I have found in training clinicians for the last 30 years is, once you've really been trained in an approach, you almost never can take that out of the person and their style of doing therapy, right? But what you're doing is you're adding more layers. And if those of you who know me, I've been working on this unifying framework where it's like pulling it and synthesizing it all together. I think is a much better metaphor than thinking, I'm just going to use this treatment and nothing else. I actually don't think that's very possible. And another myth is that CBT is like the only evidence-based approach, is the major evidence-based approach. And even what a lot of family therapists don't know is that, systemic family therapy and couple approaches have an incredible evidence base. And in many cases, they are better than your traditional CBT approach for a lot of mental health issues. And we're going to talk about specifically, couple and family group approaches today that are better than your standard CBT approaches. So So just, keeping that in mind, and what you'll find in general, if you look at the research, that the more complex and severe the problem, the more people need to be involved, meaning couple and family treatment. So when you look at substance abuse, families and partners need to be involved. When you look at severe mental illness like schizophrenia and bipolar, partners and family need to be involved. So the more severe the problem, the more you're going to find that couple and family approaches have the stronger evidence base than individual treatment. And finally, just, we hear a lot about standard practice in our field, and we often think that we're up to date because it's standard practice. And, standard practice is generally about 20 years behind the evidence base. So what researchers have found works, what the average person is doing is about 20 years behind that. And we certainly would like to work to narrow that. And that's even true in medicine. And I can tell you, doing this work for a long time, what's unfortunate in our field is I have met people who are using theories, no joke, that are 60 or more years old, who approaches that I would say, we clearly have improvements and research has clearly indicated there are better ways, but legally they're still allowed to use their old approaches, which is something that doesn't happen actually in medicine, but it is something that happens in our field. And so I think just always realizing that staying up to date is a huge challenge in our field. There's not a lot of easy ways to do it. That's part of, some of my passion, what I try to do with my teaching. But it's not an easy thing to do, even for an academic, let alone for someone who's practicing, seeing 25 to 30 clients a week. It's really hard to stay up to date. So we're going to start by looking at the psychoeducational multifamily groups for severe mental illness. And these groups are basically groups for families who have a member. Historically, this research started with families with members diagnosed with schizophrenia. And this has really expanded to a lot of areas. And the research here is stunning. But what is also jaw-dropping in the most negative of ways is that it is very much underutilized. It's one of the most underutilized interventions with a very decades-long research base. So let's take a look at these. And so, yeah, as I said, severe mental illness, we're talking here schizophrenia, bipolar, childhood mood disorders, but these are people who might be on disability due to their disorder, or their disorder is disabling for a long period of time. So what they found is that relapse rates significantly drop when you do these multifamily psychoeducational groups. So 15% of patients whose families went through these groups, relapsed versus 30 to 40% of patients who are on medication. So this means, by having the family groups, we are significantly improving the functionality of folks. And this is a huge, huge difference, 2 to 3 times, right? It is more effective and cost effective than single family sessions. So you can take the exact same psychoeducation materials, the exact same set of slides and information, and present it to someone or present it to a family in an individual family therapy session. So if, many of my clients go to psych hospitals when they have a psychotic break. And they do. Usually it's Wednesday night family therapy session at the hospital, and the families go and they can get this education, but it would be more effective if they did it in a group. And a lot of that is because of the sense of community, normalizing, and realizing like you're not the only one dealing with this. It's not your kid's problem necessarily, and realizing there are all these other people struggling. That sense of community, that sense of um, add support. It also helps, some parents realize that they do need to be doing this. There's just a reality that is totally different when this education happens in a group. And we're going to see this with domestic violence as well. So there is something very powerful for couples and families to discuss some of their most painful project problems, sitting in a group with other people who are dealing with these same types of problems, it totally changes. And so if you think of psychoeducation as this like I'm giving them information that they just need to follow through, it's totally different with this level of problem when it's done in a group setting. And so, yeah, so these family groups lead to lower relapse and higher employment rates. And if you can get someone with severe mental illness employed, again, this really does help reduce relapse. So some of the characteristics of these groups is that the key assumption is that the families of, people who have been diagnosed with schizophrenia need education, they need support, and they need assistance to cope with what's going on in their family. And that, these having family interactions that are positive increase positive outcomes for the individual patient. And so these multifamily groups, there's psychoeducation going on. They include cognitive types of interventions, behavioral interventions. They focus on emotional interventions, helping everyone cope and teaching problem solving techniques. And I think what happens is when it's done in a group, there's a lot more motivation to actually follow through on what's being learned than if it's just an individual therapist doing it. Like, and I experienced something very similar when I did mindfulness groups and training. I always recommend if you're going to learn mindfulness, go to a group because just going home, we can teach our clients individually how to do mindfulness, and the psychoeducation is very easy. But if you just are an individual client and your therapist is telling you to practice mindfulness, they teach you everything in class, you go home, chances of you like, oh, I don't feel like doing it today or whatever, and forgetting, totally different than if you're in a mindfulness group. And you know that every Tuesday night you're going to show up and there are, 20 other people who were supposed to do the mindfulness homework. People practice more, people practice longer. Just talking about it, they do more. So these groups really, really are critical for many people to take psychoeducation, psychological information, and have the discipline to apply it. And it's very different than when they're receiving the exact same information one-on-one. And all of these groups are definitely led by mental health professionals. McFarlane has a book out. It's all in my textbook if you've got the textbooks. I made my students all get it and read it in my graduate program because it's a curriculum that is available and for everyone, and it's easy to access. So, some of the core content in these groups that they cover is just the illness and medication management. So, depending on what the group is, if it's schizophrenia or psychosis or bipolar, um, mood disorders. So they're going to just go over what is the diagnosis and what the medication issues are, looking at healthcare access, um, and improving communication in the family and expanding social networks. And they get into structured crisis planning and problem solving. So, really helping the families talk through and plan how to handle crisis. Additionally, they talk about just understanding the illness, the prognosis, and available treatments. So, understanding what the prognosis is. So prognosis is how do we expect the course of this, illness or syndrome or diagnosis, whatever it is, disorder, what do we expect to happen? What are the treatments available so they can make informed choices? And a huge piece of these programs, and I do this work individually, is really teaching families about the role of emotional expression at home and relapse rates. Because one of the things we do know is in families with a member diagnosed with schizophrenia or various types of psychosis, that high emotional expression, so especially negative, tense arguments or yelling, conflict in the home really increases the rate of relapse. And so this is something I spend a lot of time on with my families who have members diagnosed with severe mental illness. that how they communicate. And what happens is it's so stressful on a family, to go through like it's like having a, they're oftentimes it's a parent with their teen or young adult going through, a psychotic crisis, being hospitalized. There's usually crisis. There's often a life-threatening crisis. So everyone's very stressed, right? And especially if they're not getting better and the treatment's not going well, there is just a lot of stress. There can be a lot of guilt. There's usually conflict between the parent. It's tough on a family, okay? And so really educating them about this role of emotional expression is important. One of the other things that they found so powerful about these groups is addressing the sense of isolation, stigma, and just family burdens. To be in a room, with five other families who also have a child who's gone through something like your child has gone through, suddenly you feel a lot less shame and guilt. There's more hope. It's probably going to be easier to self-regulate. You're going to get more support as a family, and it just makes it easier to go through it because these families do feel very isolated. Oftentimes, they're embarrassed now to tell their friends or family members what's happened. When they reach out to friends and family, oftentimes they get, not the best advice or support. And so being able to come to this group and just have this normalizing experience is profound for many, many of these families. And expanding their social networks is just critical. And then again, the problem solving, how do you handle, all the different problems that come along with having a family member, often a child or an adult child with a severe mental illness. There are a lot of challenges, a lot of problems about, just even how hard do you push? What can you expect? How to manage all of that is very important. Even just getting through the average day, like who's getting who up in the morning, those sorts of things. You help families kind of figure out how to work through that in an effective way. So, in terms of the benefits of the group process, you have the mutual support and normalization, which is just reducing the sense of stigma and isolation, which is huge for these families. Increasing hope, hopefully, through these shared experiences, especially if you have, some families who've been through it and their kid has, successfully been able to return to school or work or normal developmental life stage activities. That's huge. It's huge to hear for these families. And the social connection. And so they do encourage often interactions outside of group settings, can happen in a lot of these groups. And so what they have found is that these groups are just really significant in reducing just social and clinical issues for these families, for these patients in long-term treatment. So, and you'll find that, my experience has been that most of my clients who end up in a hospital type setting, even where you would expect this to be, these types of multifamily groups aren't happening just because they're tougher. The logistics can be tougher, and there are people who just aren't confident in knowing how to develop these. A lot of people don't even know that these exist, even psychiatrists, right? So this is a really important thing. If you have any interest in this area, I encourage you to pursue it because there's so much good that can come from these groups. Yeah, so lower stress levels for everyone in the family, not just the patient, improve employment for the patient, and just reducing hospitalizations 2 to 3-fold. That's huge. So there are a lot. So these groups are originally developed with schizophrenia, but you will see them for lots of different things: bipolar, dual diagnosis, mental health and substance, OCD, depression, post-traumatic stress, Alzheimer's, intellectual impairment, borderline personality, adolescent suicide, congenital abnormalities. So, and child abuse, those sorts of things. So there's a lot of different types of applications where they've taken the curriculum and adapted it for specific populations. In terms of cultural considerations, when they've tried to take McFarland's group, which was developed in the US, into other countries, they've had varying international outcomes. And so looking into culturally adapting the curriculum, the group format for various cultures is still needed, but it's something you will see in research going on around the globe. Okay. So now let's look at multicultural, mu- multi-group, multi-couple groups for intimate partner violence. I should not have had the culture slide so close to the multi-couple group. So this is fascinating research. So these are groups for couples where there has been violence. And I often lose everyone's, a lot of people start getting real upset as soon as that comes out of my mouth. So I want you to just hang with me. So, in terms of talking through what the research says here, so most traditional groups for domestic violence are by gender. So, typically, the most common form is a male batterers group and a female's survivors group. You do have female batterers and male kind of survivors, and you can have specific groups for same-sex couples. So, and typically, when a court mandates group treatment, if there's been an incident of domestic violence, it's very common in many states that some kind of domestic violence group is mandated by the court, and and oftentimes it's a 52-week program in a lot of the states I've been in. So, this is what we've all been used to. My very first training experience was in a domestic violence center in San Antonio, Texas. And and that's what we did. We had these gendered groups, and for perpetrators and the survivors, and we had, a gendered group for each. And they were mandated by the state, and that's exactly where I learned to do psychotherapy, people. And so what's very interesting is that we'll go over some of the research on the traditional groups. They have terrible outcomes. 0 to 5% of people get better and with what we've been doing. So even if this concept of having a multicultural, I mean, multi-couple group is really disturbing for many of us, because many of us were trained that it is unethical to see a couple together when there is domestic violence, when there's been violence between the couple. Um, that this concept of putting multiple couples where there's been violence into a same group is counterintuitive and goes against everything we thought was ethical or unethical, in the field. And it's certainly where I started. So I just want you to stay with me as we talk through this. But in a nutshell, what we have found is that these, for couples where there is only violence in the relationship, not outside of the relationship, for certain batters, these groups are more effective than the gender-based groups. Um, and the research is definitely, if you screen appropriately, they have comparable outcomes without any increased risk of violence. So let's look at some of these traditional groups, okay? Gender-based groups in the Duluth model. So a lot of these were based on Lenore Walker's concept of the cycle of violence, which is basically you have this honeymoon phase where everything's going beautifully. It's the beginning stages of a relationship, or the remorseful phase after there's been violence. Then there's tension building where the conflict starts to increase. You start to be more on eggshells. And then finally you have the acting out or the violent episode. And then that cycles back into the honeymoon tension building, acting out. And so that is, I'm hoping everyone listening to this knows the cycle of violence came from Lenore Walker's models, and actually it still holds, I think, for all these groups. So, but most of the traditional gender-based groups are based on the Duluth model, which is the wheel of power and control that has 8 elements. And the Duluth model is a feminist-based model, but you're probably very familiar with, coercion, threats, intimidation, emotional abuse, isolation, minimizing, denying, blaming, using children, economic abuse, and male privilege. So this is what I was trained on, right? This is the Duluth model where we put men into groups and tell them that you're misusing or not men, but most of the men, most of the groups I worked with were male battering groups. We had one female batterers group. So we tell the batterers that you're misusing power and control, which interestingly almost never aligns with their internal lived reality is I feel like I have no power and control. That's why I'm resorting to violence. So they don't experience it that way. So there was this disconnect. If you've ever run those groups, you're trying to, lobby and convince people you have power and control, and they're like, no, I don't. That's why I'm violent. And then you in the victims group or the survivors groups, you're teaching them these are all the ways that your partner was misusing power and control. So that's kind of how most of us were trained, and this is what I did for my first year or two as a mental health professional. So the problem with this model is that it didn't work. It just doesn't work. And even if philosophically you can agree with all these concepts, the problem is walking in to a batterers group saying you're abusing power and control, and they're sitting here going, the court's making me be here. The reason I get out of control and rageful is I feel like I have no influence at home. And so this just what doesn't work. And it didn't stop the batterers from using violence as soon as the program was over. So, and it didn't actually often interrupt the cycle for the person being abused as well, right? So if you spent much time doing domestic violence, you will find it's a very hard problem to intervene with because the batterers go back to their behaviors. And as we know, I believe this is older research, but I remember 5 to 7 times is the average number of times the typical victim will go back and retry and with after being physically assaulted by their partner. So these groups, even if we philosophically agree with them, they aren't very effective. They don't create change. So, two of my colleagues, Sandra Stith and Eric McCullum, were two who started doing a lot of this research. In Kansas is where a lot of the research happened. And what they started doing are using conjoint couples therapy for partner abuse. And so what they found is that putting multiple couples who are carefully screened, who are not severely violent, there does not appear to be a personality disorder or antisocial traits, in the person doing the abusive behavior. So you have people who don't have personality traits, they don't have a history of being violent outside the relationship, and they want to stop being violent. So they carefully screen who goes into these groups. But for those people, and if you've worked in this area, I've worked with many people who have battered their partners who want to stop, but they don't, they just would lose control, right? So that's who are in these groups. So these are what called family only batterers. They're not violent outside of the family home. They don't have severe pathology. They don't have substance use issues. They're not generally violent, or they don't have, these generally violent antisocial batterers, which, you know, and if you've worked in this area, you will know after hearing these stories that there's certain perpetrators who are much more antisocial. They're much more dangerous than the ones who are trying to stop and can't. So you're not putting everyone in the world into these groups. They are carefully screened, and these are people who the violence only happens at home. They want to stop, and they don't have other forms of severe pathology like a substance use disorder or a personality disorder. And so this type of conjoint group therapy, couple therapy is suited only for family only batterers. And so they're addressing violence for in relationships where they're already seeking violence. And those of us who are couples therapists, we know there can be violence going on with our couples and they deny it because they know that we're not going to probably see them, right? So unfortunately, a lot of clients don't even tell us because when there is violence going on. So one of the ideas here is that many of us who do couples work, there's violence going on. We don't know about it because they're afraid to tell us. And that's why oftentimes best practice is to have some individual sessions at the second session so that you can try to do your best to screen for this. And even then, you don't always know, right? This also creates a safe forum to address bidirectional violence. So bidirectional violence is when both partners are being violent towards each other. It doesn't mean they're being equally violent. It doesn't mean that the violence is equally threatening, right? So if you have a 6'4", 200-pound man and a 5'2" female who weighs 110 pounds, Obviously, there can be more of a threat of harm just based on physical size of each partner. So, but in a lot of in the majority of cases, there is bidirectional violence, meaning it's not just one person towards another, that both people might be throwing things at in the heat of an argument. Um, and so statistics indicate that there are high rates of couples who stay together post separation. And so the conjoint sessions also help directly address these issues because even if you're seeing them individually, they're going home oftentimes, or going back into the relationship with someone where there has been violence. And so having them in the room together gives some opportunities for intervention in a different way. And so, one of the arguments here is that it potentially reduces the violence more effectively because it's better able to address mutual violence dynamics. And I will tell you, when we did our, gender only and perpetrator versus, survivor slash victim groups, we acted like there was only violence in one direction, and we never addressed bidirectional violence. And it's usually there are a whole lot of reasons, but it's usually not addressed because you're trying to often get the person who is the victim here to set boundaries and stand up. And then when you start pointing out that, well, you're throwing things too, it gets really confusing. And so that typically has not been addressed in a lot of even individual work or these gender-based groups. So some of the characteristics of these conjoint couple therapy is that there's very careful pre-treatment screening to assess safety and appropriateness. So these are couples who've committed to not being violent. And if you've worked in this area with these clients, there are clearly people who are much more committed to ending violence than others. Okay. So, and you're screening for personality and substance, use issues or other forms of severe mental health. And the primary focus of these groups is to reduce violence and emotional abuse, not necessarily saving the relationship. Okay. It does encourage individual responsibility for violence. So, it's still, at the end of the day, the responsibility for violence is put on the person who commits it. And there's a lot of skill training that goes on in these groups, anger management, de-escalation, using timeouts. And one of the things I will say, talking with Eric and Sandra, who did this research, what I think Eric explained it best. He said, you can see what's going on in that room because if it's just you working with the couple, and they same thing like they did with the multifamily groups for severe mental illness, they deliver the same curriculum with just the couple and with each one individually. The group was superior with delivering the same information on a one-on-one basis with the couple, just the one couple and with the therapist. And the reason is, Eric would tell me, he says, when you can see when the batterer sees another batterer across the room do and say the same thing he says to his partner, that's when he gets it. When, as the therapist, I sit there and explain, don't, talking like that's emotional abuse or verbal abuse. They're like, whoosh, they don't get it when they have the therapist saying it. They just kind of write us all off. But when they watch it happening across the room, that is when the light goes, he goes, that's when the light bulb goes off. And he goes, that's why these groups work, is because they see it in another batterer and they don't want to be like that guy. But all of our psychoeducation in the world, we cannot convince them to stop this. But watching other people do it, the light bulbs go off. And so that was his personal take on why these groups, ended up being effective, is that they got confronted not by what the therapist was saying or their partner was saying. What really smacks them, wakes them up, is seeing it play out in front of them with some other guy across the room. So, and if you've got questions or comments, I can see comments are pouring in here. So you can put questions and comments too also in the Q&A and I'll take those at the end. But yeah, it's fascinating, right? Because I think all of us instinctually, when you hear about this, you're like, this is terrible. And then when you're like, oh, that kind of makes sense, doesn't it? So let's keep going. Okay. So Yeah, and so these groups are measured, are they able to reduce violence? And they're still not ending it like that. Lickety split is still not easy. It's a very difficult intervention, um, or a behavior to change, but they did get better outcomes, than traditional models in terms of reducing violence. And they found that the multi-couple group settings were particularly effective for men. Um, And there was no increased risk of violence for women compared to those in the traditional separated groups. So the violence rates were not worse. And they said it was even effective when substance abuse were present. And it certainly surpasses individual treatment outcomes, for individual violence. So, I mean, the truth is they still don't get huge gains, but compared to no one got better to a small percentage gets better, that's the best we've got so far that I know of in the research. Okay, so let's look at marital and relationship enhancement programs. So these are preventative interventions for non-distressed couples wanting to improve their relationship quality. And these are often multi-couple groups using psychoeducation, using often CBT. There are usually lectures, demonstrations, audiovisual practice, those sorts of discussions. So some of the major programs where there has been research are the PrEP program, which is Prevention and Relationship Enhancement Program, Minnesota Couples Communication Program, and Practical Application of Intimate Relationship Skills. So these are the ones where they've done the most research. And so the core skills they tend to teach, they're all do it in a slightly different way, but positive communication, conflict management, and positive affection expression. And then looking at the different kind of things that are emphasized in each of the programs. One is the PrEP program really works on preventing destructive conflict and communication, focusing on strengthening commitment, respect, and friendship. The relationship enhancement program is developing empathy and strong conflict management, and the MCCP is emphasis on managing conflict. So, but it's variations on really helping couples learn how to communicate in healthy ways and avoid communicating in destructive ways. And the one thing I will say, as a therapist who's been doing couples therapy for 3 decades, is with the internet and divisive politics, and the erosion of civility has done to couples communication over the past decade is really noticeable to me as a couples therapist. It's harder. And I've checked in with some of my other seasoned couple therapist colleagues. I'm like, am I just getting worse at couples therapy or are couples just getting meaner? Because getting them to be empathetic, right? I'm trained in emotionally focused couples therapy and getting to those attachment and expressing those attachment values and, expressing concern about how their partner is feeling. It does seem to be deteriorating. And so if you're interested in this area, I highly encourage you. I think there is a huge need for this. And so I encourage you to do this because I'm beginning to think this should just be part of, especially with the marital license, but I think it should be part of every high school curriculum. So let's just start with that. But these skills are really getting lost. And they even said just there's a loss of social skills with a whole generation that just not learned to communicate face to face. They have trouble reading nonverbals. They have trouble communicating face to face. And so when you get into these intimate relationships where face to face communication is necessary and you really just can't text the argument out, they're really struggling with just basic communication skills, let alone conflict. That's my observation. Um, so, effectiveness of these programs, high participant satisfaction and the learning communication skills are what participants say help them the most. The meta-analyses, so this is looking at multiple studies, show significant improvement in their skill levels and that there are long-term effects to these programs. This is impressive, 4 to 10 years. Most of what we all do in mental health does not have a 4 to 10 years of benefit, okay? Just so you know, your average therapist treating someone for major depressive disorder or anxiety, we get relapse within a year. So 4 to 10 years of improvement is huge. And so the skills are retained, but they do start to diminish after 5 to 10 years. Again, far better than what most outcome is in mental health. Um, the prep participants, specifically the research for that program, showed increased marital satisfaction, fewer divorces, and reduced violence at the 5 year follow-up. That's huge. Those are super impressive outcomes. Anyone in a long-term relationship should go through one of these programs. Um, and the greatest benefits are actually observed after several years. And what I think, in the beginning, relationships start off pretty well. And we know around the 7 year mark is where things tend to get worse. And so as the relationship goes along, the benefits become more and more clear. Even if their ability to communicate goes down, they've strengthened. When you compare them to other couples who didn't go through such training, it's more noticeable. So that's huge. It was interesting, limited effectiveness for older couple or more distressed couples. So some of the best practices. So screening couples for divorce risks and strengths before participation. So these are not groups for couples who are what are considered distressed, who would be needing couples therapy. That is very different than couple enhancement. Okay. So, you're this preventative program, you're not going to mix in couples who already have high conflict or violence or other significant levels of conflict. So you do need to, again, screen for these couple groups. Um, and you want to encourage high-risk couples to do this group sooner rather than later. So that would be, the high-risk couples were ones where they're already early, in their relationship having lots of conflict or violence or substance use issues. So you don't want to have those couples in these programs. You want to educate on handling physical and verbal aggression effectively. So you do training around all of that. Relationship benefits from enhanced program during life transitions. So having programs around childbirth, relocation, like in the military, or significant health issues and illness. These are really huge. Again, I do believe parenting programs and couple enhancement programs should be required while someone is pregnant, because especially in today's world, all I can tell you is that, having kids, what that does to a relationship, we know that it reduces couple satisfaction for years, if not over a decade. Okay. It takes a long time. And so there's so much we can be doing to prevent a lot of that with basic education. Um, so address mild distress promptly to prevent long-term relationship deterioration. So having couples learn how to identify when their relationship is becoming distressed and how to intervene early. I remember, I don't know the research study anymore, but when I was in grad school, there was a statistic one of my professors loved to cite in our couples therapy course, which is most couples come to couples therapy 7 years too late, meaning that there's the couples would report that the noticeable distress started 7 years, but it took 7 years to come to therapy. So then when they finally get to couples therapy, they're in really bad shape and about to divorce. So just knowing that as soon as the distress and regular fights start happening, you need professional intervention. And there is, and I've done a lot of couple therapies, and there is a point of no return. And oftentimes couples will cross that, and one or both still won't realize for years sometimes that the marriage died way back then, right? And would they just kind of keep a facade going for years. So learning that to intervene early with couple conflict is really huge. That adapting content for couples with mental health issues, substance abuse, or step family dynamics. Step families could definitely use their own course. And then offer diverse formats, weekly, weekends, online, to improve accessibility. And then finally, we want to end here with the last group is parent training. So parent training is huge. And again, it is another area we need a lot more of in today's world. We have, global escalating mental health issues with kids and teens. So these parenting groups are huge, and they really are the preferred intervention for basically any childhood behavioral disorder, ADHD, oppositional defiant conduct disorder. We need parent training. So certainly for ADHD and ODD, these multifamily parent groups are the preferred treatment. Not working individually with a defiant child is usually pretty pointless, although I know it's the best you can do in a lot of school contexts, but not having the parenting piece, not referring parents to an effective, strong parenting group is really important. So really an important piece here. So the core elements of all these, there are lots of different parenting groups, that you're learning how to reinforce desired child behaviors consistently, learning how to use appropriate consequences tied directly to a child's behavior, and enhancing their parents' active listening and empathetic responses to really build a secure attachment. I mean, parenting, as I like to, when I teach, parenting classes, it's like it's two basic things: secure attachment, effectively managing parenting, the child behaviors. Two totally different skill sets that really feel incompatible when the same person, has to be doing both. That's really, in my opinion, the trick to parenting is learning how to do both of those things. Most of us do one of them naturally, and the other one we have to figure out and learn the skill set to do that. So, but you need both. Neither one is sufficient on its own. And so, really helping parents with these skills. I mean, parenting, I think ideally, once you understand what needs to be done, it's a hard job, but it is a joyful job. And once you got the basics down, it's not too hard unless you make it harder than it needs to be. So encouraging the use of I statements. Some other strategies they teach in these courses. You providing children with multiple choice options to promote cooperation. At a certain point, kids also need to learn the word no, but most of the time, especially with the younger ones, would you rather have carrots, peas, or salad tonight for your vegetable? Those are your three options, right? So you're learning to give them options and using multiple choice, especially the younger they are, but even with teens, I give my kids as much choice as I can. And there are, of course, times where you lay down the law. They need to understand that too, because life will tell them no at a certain point too. Training parents to help children recognize, express, and manage their emotions. Very important. Learning how to use contingency contracts and point reward systems or I like to use natural consequences as much as humanly possible, especially when they're younger, using timeouts to reduce undesirable behaviors. And so these are some of the things you're going to see in these parenting groups, but teaching parents basically how to form effective, secure attachment while at the same time managing behaviors across, the age span. So it's different elementary school age, middle school, high school, across the various age groups. And obviously, when you switch to teens, you use more mentoring and have them solve their own problems. I try to use open-ended questions. Socratic. I teach my parents of teens how do you have open-ended questions, because you only get to have consequences for very few things for teens. Um, but these parenting groups are huge, and, encouraging your clients to do them sooner rather than later when they have children, and understanding there are very different parenting strategies for kids versus teens. But I will tell you, I am a mother of a 12 and a nearly 16-year-old, and it's just beautiful. I mean, being a parent is a beautiful thing, and I was lucky to be a family therapist who kind of understood some of the rules of what needed to be happening. And I'm sure if I didn't have any of this training as a therapist, I would not be loving these years. Um, but it's not that hard conceptually. It does take discipline and consistency. And my God, I would love not have to get up every morning and necessarily, but it's a beautiful, it's a beautiful relationship. And I think a lot of people struggle just because they don't have the right roadmap. And that roadmap is readily available and it is extremely helpful. Okay. So I just wanted to give everyone, in case you don't have it already, the QR code for my where to get forms that go with all my textbooks. I don't have forms specifically for the four theories, but I do have progress notes and treatment plans and case conceptualizations at therapythatworksinstitute.com/books. You gotta, put your name and your email in. You get put on and I will update you, let you know when the forms get updated. But this is for you. And for those of you who are kind of here with the needing your letter, I am going to go ahead and pop that into the chat. We're going to wrap up here. I'm going to take some questions as well here. But for those of you who are here live, your QR, I'm going to put the book code in. And then there is a letter of attendance link right there that you can use to get your letter of attendance. Well, I'm going to wrap up here with my presentation, take some questions, and go from there. So just to wrap up here, these multifamily, multi-couple groups have a strong evidence base. And as we saw tonight, they are better than individual couple, family, or just individual treatment for many of these very severe and difficult to treat situations and disorders. And just knowing that as a clinician is really important, even if you're not running one of these groups. I think it's real important to know. Um, and so I think that's really huge. And I mean, the other thing here is that these are underutilized, right? How many of you have seen families and not had a parenting group to send them to, right? So these are really, there's great research. They have outstanding outcomes, and we just don't use them enough. So that's just something to keep in mind. Okay. So I'm going to go ahead and take some questions. If you're here live, you can drop them in the chat. Someone's asking for the couples DV groups, is there any evidence that these are effective as an online group? I don't know the answer to that, quite frankly. So I'm sorry, I don't know how those work online. Someone's saying here that there is Hetty Schleifer has done a group therapy for couples in distress. Do you know of any other programs or protocols? I don't off the top of my head. I'm just most familiar with this one research too. Let's see, I got some question. Oh yeah, so I've got some questions here. Curriculum for couples based on domestic violence approaches. So I was saying we should do this in a simulation with me. It would be, huh? Uh, yeah, I just don't know. I don't know about the group, but most things translate pretty good to online. Um, yeah, so yeah, people are liking that. The men are looking across the room and saying that there's change. Yeah. Someone's saying, I hope they don't feel, the batterers don't feel even more powerful seeing someone else do the same. It's interesting. I mean, most of the people who are screened for the group though want to stop. And I think they don't see how egregious it is until they see it happening to a neutral third party. And they don't have people who would be getting off on I mean, they on power and wanting, seeing that as permission. But there certainly are folks. I know exactly what you're talking about. This. Uh, um, Densey's asking, how do we access screening tools when the MMPI licensing is restricted to psychologists? Well, there are other symptom inventories, and even the free DSM-5 cross-cutting symptom inventory for level one, which is free on the American Psychiatric Association's website, it actually has been eerily accurate for identifying personality disorders. I have found it fascinating. And they have two like random questions. They're just like, does it feel like, I don't know, either your life doesn't have purpose or meaning, or these really kind of innocuous questions. But every time I end up with someone, I'm like, I think they might have a personality disorder. I used to go look up on that cross-cutting symptom measure, and it was usually right. But I will say, once you have a fair amount of experience working in the area of domestic violence, working with batterers, and there are several typologies, and, there are clearly the main distinction is this someone who really wants to stop? It's only happened in the family, and there's a sincere desire to stop versus someone who has a pattern of violence. They have a pattern of antisocial features and traits, or narcissistic features and traits, or substance use issues, you can tell. And even just when someone's describing to me what their partner is doing, I can usually tell how dangerous they are. When you do a lot of this work, you've heard a lot of these stories, you begin to get really good at screening. It's not a mystery, usually who has the capacity for greater violence. So I don't know of any other pen and paper. I did most of this. The center I worked with did not use a pen and paper measure, but the cross-cutting symptom inventory, and there are other symptom inventories where you can screen for violence for sure. Okay. And in terms of which of these groups should we access training in? I mean, I think just looking for, training for people where there is some research behind or some clinical experience behind what they're doing. Oh, Michelle is asking, would I anticipate this information being on the national licensing exam? Yes, it could be. So those of you who are in my Laugh Your Way to Licensure course, there's always that 10%, right? There's a fair amount on the national exam has this incredible breadth of information. So all of this is fair game. You're not likely to see most of this, but you might have a random question, but don't twist yourself into a pretzel to memorize it all because you will lose your mind. So, but yeah, this sort of stuff could show up, and hopefully you got what you needed to answer those questions today here. Yeah, Annette is saying, yeah, there are a lot of couples who seem to be growing very cold towards each other. I would agree. There's this coldness and lack of care that I was, I'm like, am I getting old and jaded or, but this is something that I'm not the only one kind of observing this in my clients. Um, Jasmine is recommending Intimate Partner Violence Clinical Interventions with Partners and Their Children by Samuel Ayer. Thank you. So very cool. Can the clinical form be used here in Canada? The clinical forms on my website can be used around the globe. And yeah, the cross-cutting symptom inventories published by the American Psychiatric Association is actually, they're all developed by an international team of experts, and they coordinate with the ICD, which is what most every other country uses. They coordinate together. They're international teams. It's just the APA pays for the research on all of that. But you can use those across, these instruments are developed to be used internationally. There's an international team of experts for every single diagnosis working on all of the different instruments for all the diagnoses, and then the instruments that came out with the DSM-5 and the DSM-5 TR. So those you can get for free. They're great. And so I highly recommend you get those. So yeah, awesome. Okay. I see another question over here, so I'm going to hop back and forth I have various places where I get my Q&A. What is the best way to find existing groups or promote a new group? That is a great question. To find an existing group, I mean, at this point, I would do Google searches in my area and in my state, because you can practice, the online groups would be statewide. Um, and if you live in the United States, you can look for your local nonprofit organizations tend to have a lot of these groups. Hospitals and outpatient facilities, like intensive outpatient facilities, tend to have a lot of the groups that we're talking about today. And if you want to promote one of these groups, like the parenting groups, parenting groups, oftentimes schools would be a good thing. You could even promote if you have a local like network of therapists or other places that these groups are presented, because oftentimes therapists, there are online Facebook groups where you'll see people putting those groups out there. For the couple relationship enhancement, a lot of those you go through religious institutions, like, churches or synagogues. So oftentimes they will require those. So that's another place to promote those groups. But going online, even Facebook groups, if you want to promote your own group for something like the couples or the parenting, those are other ways to do it. But, I think people are hungry for this information. People are suffering. There's a lot of suffering going on. So, very good. Katrina is saying there's an A to Z mental health professionals Facebook group. Yeah, where a lot of groups are posted. So, I know California has some of those. Psychology Today, yeah, I think that Psychology Today also has online groups, and that's, I think, international at this point. So, yeah, very good. Very good. Okay, everyone. So, hopefully, this was a great introduction. If you needed your letter of attendance, I'm hoping you got it and it worked and you got the right letter. Yes, we're going to get this. I am going to probably, starting in August, come up with a new registration system for the whole thing. So, woohoo! Thank you, Katrina. I'm glad you got it. So yeah, so hopefully you feel inspired. Hopefully you got some good ideas. And at the very least, even if you don't run one of these groups, you know that they exist and you can maybe help your clients who need them get to them. Um, so very, very cool. Okay, everyone. I think I've answered all the questions. I hope you all have a great rest of your afternoon. And just so you know, next month we're doing Gottman's couple therapy. I know a lot of people love Gottman's work, and so we'll be talking about that next month. And I think that wraps up all the new videos for my Mastering Competencies, fourth edition. Only took me 2 years. But hey, well, 2 more years and we'll get the counseling ones updated and all that good stuff. So, woohoo! Thank you all. You be well. You take care. Thank you so much for showing up and making my recording a lot more fun than when I sit there and do it alone. You're the best. Oh, thank you. Happy Mother's Day to everyone listening. Happy Mother's Day. Be well and take care. Bye bye, everyone. Thank you. Thank you. I love all the hearts. I love all the hearts. You guys are fun. Thank you. Take care. Bye bye.